What's DNP? Doctor of Nursing Practitioners of Nursing Penises? What? What?
Practice.
Doctor of Nursing Practice? That's a dumb title. I think let's just start at the beginning. We're not going to get through this. I'm your host, Dr. Alexis Hazen. I'm a board-certified plastic surgeon who specializes in breast surgery and gender-affirming surgery and cosmetic surgery. I have a holistic approach to wellness and longevity. I've been practicing in New York City for over 20 years and continue to learn and educate as an associate professor at NYU Langone. Please join me in our mission to discover Zen. Welcome to the Dr. Zen podcast. My guest today is none other than Kevin Moore, who is an awesome, amazing person. He's hysterically funny. He also is a singer and used to be a performer, I'll tell you that. And he is now the assistant director of LGBTQ plus clinical services at NYU Langone. And he also has a lot of fancy letters after his name, DNP, which he'll tell us what that means, and RN. So welcome. We're going to talk a little bit about what you do and how you got involved in this.
Okay.
And then, we're going to talk a little bit about how to help trans and non-binary patients navigate the healthcare system, because it's not so easy. It's not easy for anybody. So anyway, how are you? Good to see you.
So good. Good to
Doctor.
see you.
Now I have to call you doctor.
That's right.
So tell us what the DNP is.
The DNP is the Doctor of Nursing Practice. So it's a doctoral degree that is an implementation scientist. So as I was kind of mentioning, a PhD is a research scientist. Mm-hmm. So a PhD is someone who does research and then gets publishes that, but research can take up to 17 years to actually implement into the clinical setting, which is a huge amount of time.
That's a huge
huge. And so the DNP is an implementation scientist. So we're using evidence-based practice. We're looking at the research, what research is out there, if there's a lot of it or not. And we're taking what we can find using knowledge-based theory and clinical knowledge to then implement generally a quality improvement project. So it's what we do is not necessarily generalizable research. So you can't generalize it amongst the population, but you can see if a practice makes things better for patients. And that's basically what you do. I basically say like a DNP is an operations perfectionist. Like we understand what's going on inside the clinical setting, and we see what's needed, what we need to get done now, what can wait. So really we work hand in hand with the PhDs.
Very cool. It's done, and congratulations. It's a big accomplishment to have done that. And at this late stage in your career, just kidding, but it's a lot of work, and it's really admirable that you endeavored to do that. So congrats.
Thank you.
I just wanted to talk a little bit about how you got into the field that you're now in, which is, this incredible role helping trans, non-binary, lesbian, gay navigate the healthcare system.
Yes. So, well, I became a nurse. This is a second career for me, as you mentioned.
Right, because your first career was as a performer.
No, it's shocking. Really.
No, it's not. It's so shocking.
So I was working in the emergency room and trauma in a hospital close to where I live now. And I loved work. I love being a nurse. So let me just say that right off. Nursing to me is really what I wanted to do when I was 13.
Really?
I did. Yeah.
Oh, I didn't know I wanted to be a doctor until well into college.
So that's an interesting story, right? It's
Yeah.
like, um, I was young and I was walking my dog around my neighborhood. I grew up in a small town in Pennsylvania, Westchester, Pennsylvania. And there was a hospital that was near us, and there was a group of nurses that lived in this these are big old houses in my neighborhood, and it was a group of like nurses that lived in this house all together, like 8 of them. One of them was a male, so you can imagine like me as a young person. I mean, I'm almost 56. So I remember meeting him around I was about 12, and this was really odd to meet a male who was a nurse. And he stopped to say hi, and I would see him in the neighborhood. He was very nice, and he would always pet the dog. And I asked him what he did, and he said he was a nurse. And then he told me he worked in the OR, and I was so intrigued. And I remember watching like PBS,
Oh,
documentaries,
wow.
brain surgery, and thinking, "Oh my God, this is so cool!" Like, and I wasn't grossed out,
Oh, I
right?
was just gonna say you weren't grossed out because that's
Not
a
at all.
rough
I
one.
was like, "Wow!" Watching the skull get cut, and I really loved it. And I was like, "Okay, there's something a little bit uh, like sadist
That
about
and
this."
horror movies.
Totally love them too.
Hmm.
So nonetheless, I around 13, I told my mom, and to which she answered, I told her I wanted to be a nurse, and she said, absolutely not. Now remember, this is 1981, right?
Why would she say that? Because you're a boy?
Gendered. It was gendered, yeah. And she said, absolutely not. That job is for women. And you are not going to be a nurse. And I was like bawling. Uh, and but I was thinking now. Fast forward, my mom passed away a number of years ago, but she was so proud of me becoming a nurse. So there was a lot of changes. She was exhibiting a protection for her child because she
Sure,
thought,
sure.
"Wow, you're really gonna have a hard life." But
Yeah.
anyway, so
I had the same
I
thing in the other direction. So I had.
Okay, question. Hands better. Can you see them?
Personal shots.
Very personal. I plan on getting extremely personal. I'm a mom. Hey, Spence. And a plastic surgeon, and a proud pet owner of 2 naughty cats.
Boonsy, you are such a. Oh, yeah. Now you're gonna claw me.
And a very naughty dog. Yeah, aren't you a good girl? And I'm super happy to be here to tell you a little bit about myself. See, you didn't drink your coffee, now it's cold.
I love a lukewarm.
I do, I like the lukewarm. It's so perfect. So when I graduated in 1987, it was the middle of the AIDS epidemic, and I was obviously concerned about it and interested in helping people. So I took a job at the New York City Department of Health doing AIDS education and outreach. And it was really fascinating and a really rewarding job. And after that, I sort of sparked my interest in healthcare, and so I ended up going into the Peace Corps. I was a healthcare worker, and I lived in a tiny rural town in the middle of nowhere. There was no running water, there was no electricity, and people were like dirt poor.
There we go. It's so funny because I always talk about this a lot. Like, I'll be just because of my gender and presentation, that I'll be mistaken for a doctor all the time when I
Oh,
walk in
all
a
the
room.
time. All the
All the
time.
time.
I'm
And then
sure.
people, yeah,
And now
they
you
do.
are Dr. Moore.
But it's so fascinating. So anyway, I was very excited to become a nurse in my later age, and I worked really hard, and I'm so glad it happened as a second career, because I really was motivated to do it. And so I was working in the ER and trauma, and I had a friend who transitioned many moons ago, my best friend, and I learned a lot through his experience. And so I was working in the ER, and there was a trans woman who came in, and she had this was before the Affordable Care Act and the coverage of gender affirming care
So what
under
years are you talking about?
2011,
Okay.
2012. And so she had, what I didn't know at the time was free silicone injected into her breasts and some around her buttocks and
Yeah,
face.
it's really common then. I
It
see
was
it all the time.
so poorly inserted, right?
Mhm.
So this was like she had multiple uh, uh, dimples all
Yeah.
around her breast, and they were malign. They were, one was much bigger than the other.
Mhm.
She had abscesses on her legs
Oh,
from injecting heroin with, excuse me, not heroin, because that's what I keep thinking of. She was injecting estrogen into her legs, and
and
she,
getting it on the black market.
yep.
Yeah, right, because people
So
couldn't get hormones then.
you're so desperate,
Yeah,
and we didn't have any accommodation. We didn't know how, everybody was using her dead name, which I knew was wrong, but the hospital was like so uneducated,
yeah.
and along with the rest of the staff, and she just took it, and
Yep.
I couldn't believe what I was seeing and what I
Mhm.
felt.
Like
I
the
almost,
bad care, the lack of
terrible.
kind of respect,
There was
basic,
no empathy.
basic stuff. Yeah.
And I literally remember I put, like, we had we had the curtains. And so I put on the curtain, see nurse before you walk in, because I didn't want anyone misgendering her.
Yeah.
I wanted to tell them what her name was before they went in. I remember, like, I felt like I was standing at the bay door, like, don't
Yeah.
fucking,
Don't mess with us.
yeah. So, and I never forgot her. And so I ended up going to, uh, it was a magnet hospital. So what that means is, like, nursing has a voice. And so we had these unit practice councils that looked over the unit, and all of us would, work together and, try to change things and make better practice for nursing. So I went to the unit practice council and I said, we need to do something about educating people around trans and trans health. And they were like, well, why? And I told them of the experience, and they said, well, we don't really get a lot of those patients. Now, it sounds
And then,
very,
and I'm going to point out, like, one thing I sort of meant to say at the beginning of this is that the language changes. And so, it used to be the way we talked about transgender folks and about transitioning is very different than now. And we didn't even speak about non-binary patients because, we
no
didn't
such thing.
see them. And
No.
so now, we have to constantly change the language. And if someone listens to this podcast 5 years from now, it'll probably sound very outdated in terms of whatever the language that we're using now. So I just apologize in advance. But yeah, you were talking about
language, right?
Yeah.
It's a living language. It changes based upon the population,
Yeah.
truly. So, so it just really stuck with me, and I thought about her, and I thought, no wonder we're not getting people like her, because no one really cares. But it was also the level of ignorance and the presentation that was there. This is, again, 12, 13 years ago, right?
Right.
So so I ended up staying there for a while. I left. I went to another hospital, a very, very famous cancer hospital. And
Shall remain nameless.
and I loved the people I got to work with at night. I
Mhm.
loved the patients. The place itself was just way too stuffy and conservative, and just it wasn't the right fit for me.
Mhm.
Nonetheless, when I talked to them, their unit practice council, which was new because they were just becoming magnet, they were basically like, well, we don't do that. We're just about, like, bringing cookies to the other units. Like, it was like, what are you talking about? So I thought, well, they're there for like a show, not for anything as an actual resource group. Fast forward, I ended up at NYU. I ended up becoming a member of the LGBTQ plus advisory council, which is a very strong employee resource group at NYU.
And you're still involved with that.
I'm still involved with that. My role really takes me away and has me quite busy, but I'm absolutely still a member. And I met many, many people, a few in particular, who were passionate about trans care, trans health, educating the system, making people more aware. And that's really where I was like so excited, because I was like, oh wow, there's more people like me that feel this way. And then of course I met you. My very long story to get to you, but I met you, and you were taking care of a lot of trans men and top surgery. And I was so excited because I finally was at a place, and here was a physician who was doing this work and had been doing it for quite a while. And I talked to one of the residents, and they were like, you should absolutely talk to Dr. Hazen. You know, she's been doing this a long time. She'd be a great resource. So then I came to you and I was like, Dr. Hazen, Dr. Hazen.
You were like tugging on my shirt tails.
I was so excited.
You're like, I want to work with you. We should do something. We need to get a program. And I was like, great. Well, actually I was, because, you know, I'd been doing this work for a while and I didn't really have any support. I mean, people weren't blocking me, but they weren't supporting me, and there weren't resources, and there wasn't any training for staff to talk about pronouns or, you know, dead names. Nobody knew anything. And
it was not unusual for patients to have top surgery, right? And then for the charge nurse, who was not, this is not nefarious, right?
No.
Charge nurse would go over to the patient who looked like me and just had top surgery.
Yep.
Not that, but looked like me. And they would say, what room do you want to go to?
Meaning,
And
what gendered room do you want to go to? Right.
No,
that was a big deal. It was a big deal, you know, kind of navigating what gender room people would go to.
And here's the thing, there was a law on the books, but none of us knew it because there was no education about this.
Right.
And so the patient, and still to this day, I always say this, that the patient is left up to the mercy of the system and the system's failures. So
100%. And this goes for, you know, all, not just issues around trans and non-binary folks, but, you know, all aspects of healthcare.
Yeah. And you could get someone that comes in, like say a patient comes in and they say you and I, and they have a great experience because we get it. Or you can get someone who has no exposure, no education, is misgendering, doesn't understand the importance of recovery, doesn't understand that misgendering should be taken as serious as a medication error, and sort of just flops. And then the patient this all falls not on the system, on the patient.
On the patient, absolutely.
Experience. So that is something that became very, very essential to really try to mitigate and change, because the culture there was definitely people who were interested and wanted to support, and then there was definitely people who were like, whatever. So I focused on the movable middle, which is what GLAD calls it, right?
Oh yeah, that's good.
Movable middle, right? The people that were like, I don't understand, I don't get it, but like, can you tell me a little bit more?
They were willing to learn, and you had a captive audience.
Yeah. And, you know, it changed. And people got more educated, and people took misgendering more seriously, and it got better. It's not perfect. I don't think it ever will be, but I think it will certainly be more conscious. And now there's also resources. So patients don't, hopefully, you know, if something happens, patients have an advocate and an ally to stand for them and make them feel safe and taken care of. So.
Well, I mean, that's so important. And especially when you're in the healthcare system, presumably you're there and vulnerable, because either you're ill or you're having surgery, and those are both really vulnerable situations. And then to add on top of that, you know, this whole layer of complexity, so important to have people who understand and are, speaking the language that you speak and addressing you how you are comfortable being addressed. So now tell us a little bit about your role now as the Assistant Director, Clinical Services for LGBTQ plus. Trying
So
to, it's so many, it's a lot of consonants,
it is LGBTQ, LGBTQ, LGBTQ. And then people are like, why don't you have the IA in there? And so it's always like, really the truth is that people search LGBT and LGBTQ far more.
Yeah,
and they
right.
internet. So that's the reason it's easier to find me. But also plus becomes the multitudes of identities that are a part of the LGBTQ plus community. So, and by the way, in case anybody's wondering, I stands for intersex, A stands for asexual. Some people say asexual or ally as well. So, nonetheless, so it's a very, I was really allowed to innovate a lot with this role, which I'm really grateful for. It actually had
you've done so much. It's amazing.
It had no clinical calling to it when I first started. It was all about, it was inpatient experience, which was a really good place for it to be.
Yeah.
And it was about like really just taking care of the patients in terms of, are you okay? What do you need? Making them feel safe. So, and helping them through the system. But you get so busy, you can't do that for every patient. I mean, I literally did it for almost 500 patients, 320 the first year, 500 the second.
I remember we used to call upon you when we had trans and non-binary men, or trans men and non-binary folks who presented as men and needed to get a mammogram. And the place to get a mammogram at NYU is the women's center. And it's, you get there and they put on the pink gown, and there's a common waiting room. And so you switch into the gown, and then you're like cordwood with the other patients. And so you helped our patients, get mammograms and feel a little more comfortable and more safe and more seen, because that's a really horribly uncomfortable situation to be in. And that's just one example, but there are many other examples of things that you did, and you shepherded those patients through the system.
And I learned a lot, right? I learned the fear and the worry and the concern, and that was not even about the surgery or the upcoming. It was about
it's about the other. Yeah.
So I learned a lot, and it really motivated me to want to make a difference for them and for the people that worked with me, and who I'm not going to say everyone, but really for the large part, people were unaware. It wasn't nefarious, but they were really unaware. And so
much ignorance around this.
There is. And I always say, like, Epic and our system, any system in healthcare thinks like a cisgender heterosexual. That's what the healthcare system thinks like. So to make it not, I always say, like, all we're doing is creating a little pathway that everybody else has a big lane to get into, just a little one over here. Helps people get on to the same area. So, and that does require, imaging is a big place to educate people. We now have a place where we send people to get imaging that has education, and people get it more there. Gynecology is another place, very gendered, where we have people that people can go to and feel affirmed. But we're still I think everyone is building these services to create a better patient experience for people. So largely it became clinical in terms of the gender affirming surgical experience and getting people to the right providers when they needed them outside the gender affirming surgical experience. And my experience in the hospital and in healthcare really was important. And I would also say my experience as an actor, working with directors and people with big personalities
Mhm.
to navigate systems and be comfortable talking to anyone from the CEO to the security guard, you
Mhm.
know, that I could navigate those systems and be able to be malleable in situations to help people understand. And here's the deal. I always approach anything really. My first instinct is to approach with kindness
Mhm.
because I feel like I respond really well to that. So I want to approach people with kindness, and I'm not there to help people understand. I'm there to help people gain knowledge, to empathize,
Mhm.
and treat people with dignity and respect. If you happen to understand, that's great, but I don't need you to do that. I
Mhm.
need you to treat people with dignity and respect. I don't think that's a big ask.
I, I don't either. I mean, I am in fact shocked that, but it's people, physicians, nurses, hospital administrators are people, and they have their unconscious and conscious biases, and they may be religious, and they may, have a lot of fear. And so, that's where we are. And unfortunately, you've got to kind of deal with that fact. Do you feel like
Oh,
being,
I've had the whole gamut too,
yeah,
like
I'm sure. And
crazy responses.
you feel like being a gay man helped you kind of be more sympathetic or empathetic?
Oh, sure.
Yeah.
Yeah. I mean, I'm a member of the community. I was as a child, I was really pegged quite early. I very happily identify as someone who loves being feminine. I love my femininity. I think, and honestly, it was working with trans people that made me realize that it's the best part of me. Uh,
Hmm.
it's the part of me that helps me be kind and be empathetic, nurturing, um, uh, and caring. So absolutely. And as a child and growing up, I was very, very bullied, like heavily, heavily bullied.
Oh, really? Where did you,
Yeah,
you grew up in Pennsylvania?
yeah. And I went to a parochial school and private school, and it was just torturous, and it really damaged me.
Oh.
And I feel like, again, I know this sounds odd to say, and hindsight is 2020, but I'm so grateful because it's that experience that really made me. It's a place where I didn't have a voice,
Mhm.
where I was quiet, where I went internal and I brutalized myself. Um, and now, here's the gift of the universe is getting a job where I get to be the voice, where I get to stand and advocate in not just in spaces where I'm with trans people, but in spaces where I'm not, and I need to speak up and represent because I am an advocate and mention, hey, by the way, we're in this very high end meeting with a lot of administrators and there's no one trans here and we're talking about trans people.
Yeah.
So that's something that I don't think I could do without the experience that I have now at work, but also from my childhood.
Mhm.
So yeah, I think absolutely it has absolutely benefited me.
And one of the things that you've worked a lot on is the systems. And
Mm.
I remember when I first started doing this work, one of the big problems was the electronic medical record didn't have didn't have the language. And so, there were only two genders, and there was, your legal name. There was no place to even put transgender, or there was certainly no place to put non-binary, and there wasn't a place to put any other than your legal name. And I remember we used to have, well, then we had paper charts also. And so we had stickies on the charts, and, pronouns are, but even, and now I'm going back 15 years, and people were like, what's a pronoun? I mean, they had no, right? And then I remember
I still
talking
get that.
talking to administrators about the Epic system, and,
Yeah.
could we change it? And they kind of looked at me like I had 10 heads,
Uh-huh.
but
Especially 15 years ago, right?
it did change, and you
Uh-huh.
were part of that.
Yeah. So it was one of the first things I got the great good fortune to work on. Um, people always ask me, how do you do this? If you're at another, like in another, how do you do this? And I say exactly what was told me: build your team, right? Find who's your ally, find who wants to help, find who is and is on different teams, right? Like the people that can help you help people.
Yeah.
So, and I say great good fortune because informatics or the electronic healthcare system and the personal healthcare record are something that I was truly not drawn to at
Oh,
all.
no, I mean, same. I mean, it seems so
Anyway,
weary and boring.
like,
Like,
like I thought,
right.
no, like,
I,
all great for you, but like, why would you want to go into that? And so the truth is, what an amazing group of people. And it was something where I saw yet another area that drew a marginalized group of people into a conversation for
yeah,
exactly the reasons you just mentioned.
right.
So, so we were able prefer. So I'm going to use Epic speak. Epic
Mhm.
says preferred name and the community says chosen, right? So preferred name, it was this big. It was like this big, and then legal name was like this big.
Mhm.
So as a clinician, you couldn't barely see the chosen name, right? And then what we did was reverse it. So we made chosen name really big and we made legal name really small. And then we were able to put gender identity and pronouns below that chosen name. And then we were able
Made it
to
the game
put
changer
chosen
because
name on
then
the
people
wristband.
would see it and they could appropriately address people.
100%. And the chosen name was on the wristband. Pronouns were really large in the clinical header. I will never forget the day that happened. I remember the exact day it happened. It was
What
December
year was it?
2018. We started in 2017.
Yeah.
And it
And
was
really before that, because I remember we were talking about it, but it was at the level of like, this is never going to happen kind of thing.
oh my gosh. Well, it was really a big deal, right?
Yeah.
And it was a lot of people that were involved in it. And it was December 8th, 2018, when we switched over to the new upgrade in Epic. And it was your patient, actually, that I went into their room that morning, and it had taken effect the next day. And I said, and he was a young person,
Mhm.
like 19, I think, or 20. And I said, oh, hey, can I see your wristband? And he said, yeah. And he lifted up his wrist.
Oh,
Not to get emotional about this, because
no, I'm the same way when I talk.
he lifted up his wrist and I said, oh, look, it's your name. And he goes, yeah, isn't that cool? And I was like, yeah. And I walked out of the room
Did you
and
cry?
I bawled
Oh,
because I realized, one, it had finally happened, everything we had worked for
for years.
here, and that also that it wasn't a big deal to him. And that's exactly the way it should be.
Yeah.
It was just there, and
Yeah.
he could just be. He didn't have to be like, look at my name. He was just like, wow, isn't that cool? Yeah, that's really cool. And and I thought, man, this is going to affect people I'm never going to meet. So, and that's when I really started to realize that policy was something that another place where I could really push and have an impact for patients and staff,
Mhm.
um, in ways that were beyond the bedside. Uh,
Let's talk a little bit about that because you have done so much and you have written policy for employees and for patients. And so tell us a little bit about the thing you're most proud of.
hmm. I would say for staff, I'm most proud of the transitioning on the job guidelines.
Okay, so this is huge. So
Yeah.
until you worked on that, there were no guidelines, just like there's no maternity policy for residents, there's no,
Don't
there
get
were no
pregnant.
guidelines for, how do you navigate that? So,
So I'm part of my job is responsible for the recertification of our Human Rights Campaign Health Equality Index, which is a health equality index certification that looks at healthcare institutions of employees of 100 or more.
hmm,
and it looks at patient and staff facing policy to make sure that there's equity across the board. Now, if you're a space in New York, you should be getting that pretty easily, but much commending to the HRC that it gets more challenging and more difficult each year. So you have to step it up each year and get better and better at this. And I would see like this policy, like, do you have a transitioning on the job guideline? Do you have, and I was like, we don't. So I started to look and I started to get really familiar with what those look like. HRC had an example. There was another one from the Trans Equality Center that had one. I was trying to get a hold of another healthcare institution, but couldn't really find one that was available. Not that I think there was one other hospital that had one. So I had a friend, a colleague who was a leader, not a clinical leader, but a leader in another department, in our real estate department. And she was transitioning. And I said to her, would you be open to sitting with me and working with HR to make this policy guideline for people? And she was like, absolutely. And so HR was really open to it. And we sat down, and it took us about, oh my gosh, I think it took us almost 18 months because we really got down to the nitty gritty. And,
That's
because
good.
you can look at it was really, it was well researched. And we also wanted to make sure that, you look at these other things, but you have to make it your institution's own. And, I work for a large institution, so you want to make sure that it has those pillars that the institution believes in.
Mhm.
And I always really think like that. Like I have to think like, what would the institution think? And let me make sure that that is brought in. Um, and here's a good place to say, I'm an advocate at my job. I'm
Yes.
an activist in my life. I'm an advocate at my job. So, so we built that. That came out in 2019, Pride 2019, and it's been used a lot. It's been copied by the University of Pennsylvania Medical Center.
Oh,
Uh,
great.
John Hopkins has recently asked to copy it. So I'm so proud of it.
Yeah. Oh, that's
Because it's
amazing.
going to affect
Just,
many people.
it's so important. So what advice do you have for trans and non-binary folks who are trying to navigate the healthcare system?
Mm.
I feel like you have so much experience, helping people do that. Well, there are a lot of places that aren't like NYU that don't have, an advocate. So what do you think is important?
Well, I would say ask your friends. um, especially for trans and I'm going to focus on that, trans and non-binary people. It's not like if I was a trans man, and again, for people who are new to this language, a trans man is someone whose sex assigned at birth is most likely female, and their gender identity, when they look in the mirror, they feel male. So a trans male to go who needs to go to the gynecologist to get a checkup, you just can't send to any gynecologist.
Yeah.
So there's so much to consider, right? So, the office, the atmosphere of the office, are they going to be comfortable in the office? Are they going to be affirmed when they're examined? Like all those things. So, I would never tell anyone, even in our system, to just call someone, that you find on a website. So ask your friends, and that's generally a good place to start. You can also look at your local LGBTQ center. And I'm thinking, Dr. Hazen, people like in rural areas, right?
Right.
Rural Kansas,
Mhm.
but or other places. Well, we won't talk about the places where they're trying to outlaw the care, which is egregious. But that's also to look online, like in private Facebook groups or Discord or any of those groups that you're a part of, where trans and non-binary people have found safe spaces largely to find out that information from other people.
Mhm.
But in terms of what I do, I have a list that I've created that has proficient providers in almost every service area. And I always hope like people can find me. I wish that there was more marketing of me, so to speak, in terms of
Mhm.
like, so people can find, oh, I can get there and he can get me the information. Um, because that's really how you get there. Like, I'm going to send people to the right people.
Right, right.
So, people that have been vetted, the office has been educated. And if it's someone new and if I haven't had the chance to educate the office, I will tell the patient.
Mhm.
I also send people to physicians who aren't in the system,
Mhm.
um, because it's about trust.
Yes, absolutely.
And I want patients to be taken care of no matter where they go. And
Mhm.
I've had other providers from other systems call me to send their patients to providers with us that they feel safe, where they can't find those services in their system. So I think those are the best ways to find out. HRC does have a list. That's the Human Rights Campaign. If you just put Human Rights Campaign, LGBTQ medical providers, they're coming out with the laces. So that's another way to find
Okay.
providers. You can look to those lists.
These are great ideas and great resources. And what is missing still?
Um,
Like
I would
where do you think there are real gaps?
systems. So I think it's our systems. And I say our, I mean all of our systems.
Mhm.
I think uh, everyone needs to be educated.
Mhm.
And I want to be very clear about what that means. Everyone needs an awareness,
Mhm.
right? Everyone needs to have an awareness about what sexual orientation and gender identity mean, why it's important to collect that information, and why it's important to our health,
Mhm.
um, all of our health, no matter if we're cisgender and heterosexual or if we're trans and queer, So,
And cisgender for our listeners just means that you identify with the gender that you were born.
right, right. So, uh, like, I look in the mirror and my gender identity matches the sex I was assigned at birth, right? So, I think that's a big piece of it, and trying to give people that information that helps make people more aware. We're just about to do that, by the way.
Mhm.
So we're going to be making sexual orientation and gender identity mandatory. Um, so right now it's only at the point of care. So that means when I come in to see you as a provider, you someone like you would ask me my sexual orientation and gender
Mhm.
identity. But not
And why is
everybody.
that important? I mean, I agree, but just for our listeners, why? Because it seems invasive, and what does who I like to sleep with have to do with anything? None of your
Well,
beeswax.
yeah, it's a great question, right? Why is it important? Um, and some people might say, well, I understand gender identity is important, but why do you need to know my sexual orientation if
Right,
I'm getting knee operated on,
right.
right? So, and I would say,
Just nosy.
why do you need to know the color of what my race is, what my ethnicity is,
Yeah.
right? We don't have the data. We need to understand, and a lot of the data is anecdotal, except for tobacco. So, because the Department of Health keeps data on LGBTQ people and tobacco. So, we don't understand largely the impact of health disparity on LGBTQ
Mhm.
people.
Right.
And it has been recommended by over 20 different major medical and nursing organizations to collect this information since 2011.
Wow, that's a long time.
So we don't know right now. We've done it in the Perlmutter Cancer Center. We've collected sexual orientation, gender identity, and in some of those DRGs or disease resource groups,
Mhm.
those we have collected 96% of the patients. We've
Wow,
collected sexual orientation and gender identity.
amazing.
It is. So if I'm a gay male and I have prostate cancer, that's important information.
Right, right.
How do I know what resources to give them? Do you
Diseases
know
may progress differently.
exactly?
And
And
the
you also
exposure, you're exposed to different diseases, right? That's a
and
really
then
good point.
recover,
Mhm.
right? What are the things this is social determinants of health? What are the important things to that person? So I've had cisgender or not trans gay men who have receptive anal sex who are scared now after prostate cancer treatment to have that. So, what's available to them? How do they recover? Taking their sexual health into consideration, which is so important to all of us. But it's understanding why that's important. There's so many providers that are so uncomfortable with that information from their cisgender and heterosexual patient population, let alone their LGBTQ population. And physicians especially are trained, they're trained to heal, right? Like get to the disease or get to the problem and fix the problem. And, the really great physicians think outside, like they think holistically.
Right, about the whole body.
That's right.
About your sleep, about your anxiety, about your sexual identity, about your gender identity, everything. It's all important.
And where a nurse is really, that's our goal, is to really think, okay, help you heal that area, but also, again, just like you were saying, what is the impact on all of you?
Right.
Do you have the right social support to recover from any surgery? And if you don't, how do we get you that? Even, do you have access to food? Are you in a food desert? Like, we don't even know that about LGBTQ people.
Right.
We don't know about cardiac disease in LGBTQ people. So it's really, really important information for us to really understand how to really treat people in a way that gets to the problems, right? I'm excited to tell you that I have been working for the last 6 months or more with the population health department at NYU, and we are adding LGBTQ people to the community health needs assessment.
So good.
It's the first time any institution has actually added LGBTQ people for 2025 and 2028. And we're really investing in focus groups and really going to be talking to the community. And I'm not talking about like the larger healthcare organizations. There's great federally qualified health centers. I'm talking about the real small ones, the ones that are doing the work that don't get any attention and don't have the resources. And it's exciting because we're going to be able to hopefully, find out where some of these holes are, also using some of the sexual orientation, gender identity that we're going to collect to address some of the issues like navigation in the system, getting more navigators that are LGBTQ proficient, that reach out to the communities, not just in Manhattan, but in Brooklyn and Long Island, in our new hospital that we are dating, but we're going to merge with this Long Island Community Hospital in Suffolk County.
It's so important. We've got to finish up now, but I just appreciate you so much and all the work that you've done for the community and your outlook. And, in addition to being kind, you're also very funny and humorous. And I think that really goes a long way in stressful situations. So thank you for being my guest. I love you. You're the best.
Thank you so much. And thank you for asking me. And really thank you, because honestly, I would not be here doing the work that I'm doing without you and your inspiration and your kindness and your goofiness and loveliness and your humor. And I'm really, 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 truly grateful for you.
Thank you. Thank you so much. And we'll have you back on the show in a few months to give us an update.
Awesome. I'm looking forward to that.
Kevin Moore, Dr. Kevin Moore. Thank you.
Bye. Love you.
Bye. Love you.
Zen Essentials, because your health is essential.